Okay, we're going to combine them all. This is kind of a combination of metabolism, a little bit of elimination, um, and a side of infectious disease. So we're kind of hitting a couple different concepts here, but we're looking at assessment and management of clients with hepatic disorders. In your book, this is chapter 43. It's a pretty significant, hefty little chapter, but we'll try to get into it and make things simple and make sense. All right, so thinking about the anatomy and physiology of the liver and biliary system, it's the largest gland of the body. It's located in the upper right abdomen. Hopefully, that's not news, but that's where it is. Very vascular organ that receives blood from the GI tract and the portal vein and from the hepatic artery. And I always say the liver, probably one of my favorite organs, just because it can be regenerative. However, you almost people I think fail to realize all the cool things that the liver does until it's broken and then it's not doing any of those things anymore. So let's keep going. So we just kind of look at this as just a quick overview, like picture of the liver and kind of pancreas and gallbladder and where all that stuff hangs out together. So just kind of an overview if you don't remember. Hopefully you had anatomy and you do. Metabolic functions of the liver, it does so much, but the liver manages your glucose. So after a meal, glucose is converted into glycogen and is stored in the hepatocytes in the liver, and then is converted back to glucose and released into the bloodstream to maintain normal levels of blood glucose. So putting that together with clinical application, if I have a client with end-stage liver failure, I could see them becoming hypoglycemic because that function is not working of the liver. So again, thinking about how does this apply to my patient, thinking about what would I see here. Ammonia conversion. The liver is a takes that byproduct ammonia from gluconeogenesis. So again, when we're making those, a process where we're using amino acids from protein to break down or lactate produced by exercise, in response to hypoglycemia. So basically, ammonia is this byproduct that's made and kind of can build up in the bloodstream, and it also can be produced in the intestine. So the liver's job is to convert this into urea, and it's excreted and through the digestive tract. You basically kind of poop it out and get rid of it. But again, how does this affect my client and my patient? If their liver is not working, what you end up seeing is a buildup in ammonia, and because the liver's not able to do its job, the client can be confused and get what we call hepatic encephalopathy because the liver is no longer converting ammonia like it's supposed to. The liver also metabolizes protein. So, protein synthesis, almost all of the plasma proteins, blood clotting factors, transport proteins, plasma lipoproteins. The liver is doing so much and we don't think about it. It's doing so much, hard working every day. But the liver requires vitamin K for synthesis and prothrombin and other clotting factors. So when we think about a newborn baby, if you remember, when babies are born, they usually get a vitamin K injection because their livers are immature. And so, because the liver is not doing that job, what you'll see with babies, one, they get that vitamin K injection right away so that their clotting factors start to work, right? But then also, when we think about a newborn baby and that immature liver, that's where we see the jaundice, et cetera, et cetera. So, in a client with end stage liver failure, again, clotting factors are broken, they're at risk for bleeding, they have poor protein metabolism, and that means even some absorption issues. So they'll start to look kind of wasty because their body's not able to take that protein and do anything with it and synthesize the protein. So that's where they start to kind of look skinny but like loss of muscle tone. So again, clotting factors, huge, huge, huge. So if my liver is not working, those clotting factors are not working. So think immature baby liver vitamin K injection to help promote that. But if I'm in stage adult liver failure or have a congenital defect where I had an issue with my liver, et cetera, whatever, if my liver is not working, those clotting factors are not working. So what does that mean? I'm completely at risk for bleeding. The liver also metabolizes fat. So fatty acids are broken down for the production of energy and ketone bodies, basically the small compounds that can enter the bloodstream and provide energy for muscles and other tissues. So fatty acids and their metabolic byproducts are also used to synthesize like cholesterol, lecithin, lipoproteins, and other complex liquids. Again, so you can see there's some nutrition issues if that's not working. The liver also stores vitamin A, B, D, several B complex vitamins, iron, and copper. So basically, again, thinking about mineral and vitamin deficiencies if my liver is not working. Crazy, but it's true. So the liver does so much. Anyways, did I mention it was my favorite organ? Bile formation. So the bile is continuously formed in those hepatocytes and collects in bile ducts. It's basically kind of like composed of like water, electrolytes, sodium, potassium, calcium, chloride, and bicarb. Lecithin, fatty acids, cholesterol, bilirubin, bile salts, kind of all like stored in the gallbladder, but it's emptied into the intestines as needed for digestion. And again, if there's issues with that circulation, issues with that portal vein, anything like that, you can have issues, or like people can actually have um, like hypertension in those veins as well. So again, we're just having issues with all of those systems, liver, gallbladder working together so they can get blocked or they're just not working. But the liver is key in bile formation, so that and aiding in digestion. So that is huge. So sometimes we think we're having a gallbladder issue, but we actually could have a liver issue. So bilirubin secretion, that pigment obtained from the breakdown of hemoglobin. So bilirubin is just truly a yellow colored, kind of oily looking thing. But it's basically a byproduct. We break down hemoglobin and it's basically conjugated and then it's secreted into bile and then into the duodenum, like into the intestines, and then excreted through the bowels. So, or absorbed and secreted through the kidneys after it's processed. So what you can see a lot of times the people that have liver failure, this process isn't happening either. So they have elevated bilirubins, and that's where you start to see the jaundice. That's where you'll start to see if they have a catheter or they, when they urinate, it's almost like oily in this super crazy color yellow. Or the same thing when they have a bowel movement, it's oily and yellow and, you know, kind of literally runs right through them. But basically, and then that also, that's where you get the jaundice and then that byproduct of being itchy and pruritus. So again, the liver is doing so much. Take care of your liver. Drug metabolism, it metabolizes so many drugs. So when we think about that, when we have that hepatic considerations, when you read about a medication, this is why. So basically, it metabolizes so many drugs, but then also helps activation, that first pass effect with medications. If you remember that from when we did our Farm Made Easy about how medications work. So because that is limited, that's where you start to see people with end-stage liver not being able to take certain medications or not, like just a classic acetaminophen is processed in the liver. So if somebody has end-stage liver failure or, problems with their liver, we are not giving them Tylenol. Any kind of gerontologic considerations, there is a little chart in your book, but most of the changes is decrease in size and weight and blood flow, and again, that portal hypertension, et cetera, et cetera. So basically, with aging, sometimes but as a result, sometimes, and it's kind of interesting to see, but like with aging, those liver hormones those liver function tests, when we look at the blood values and draw liver function, um, they can maybe don't change with age. So basically, you may not see a change, but it's because it's just um, it is not functioning as well. And the same kind of interestingly, like if somebody has like alcoholic cirrhosis or any kind of or non-alcoholic cirrhosis of the liver, sometimes those will shoot up and they'll have high. Those liver function tests, all those lab values will be elevated, but then they'll kind of normalize as the liver dies, which is kind of sad and terrifying, but it is. Again, the liver does so much. Beware, be noted, make it make sense. But the liver does all kinds of things. So if it's broken, we can have all kinds of problem. Again, it's right here. Liver function test. There's a table in your book that kind of talks about them, but it is serum. I'm not going to get into the names of them, but basically your AST, I mean, meaning like I don't say the word well, but it's right here. Aminotransferase, AST, ALT. There's again GGT, GGTP, and LDH. But typically, what you see the most until you break it down into really specified tests is you're looking at your AST, ALT, and then probably maybe the LDH. You look at serum protein studies, even albumin, bilirubin, urine bilirubin, clotting factors, of course, because again, think about all these things that the liver is doing. If it's not working, we're looking at all these pieces and byproducts and things that might show up in the blood as a result. Serum ammonia, lipids, serum alkaline phosphatase. So all of those are in there. And just thinking about, there's again a quick table in your book. It talks about the clinical function of them a little bit more if you want to get a little bit better understanding. But just know that these are the tests that we're running, and then also just kind of think about the why. Again, all about back to that, the function of the liver. We're looking at these liver function studies as a result, if we're seeing where things are kind of breaking down as a result of the liver functioning. Again, additional liver function test. Again, that serum amino oh my gosh, serum aminotransferases. Again, it indicates liver injury, injury of those cells. The ALT looks at like liver disorders, monitors the course of like hepatitis and cirrhosis. And again, sometimes those can level out after a while, after the liver just completely starts to cirrhose and die, unfortunately, but they can continue to go elevated and elevated. AST, the aminotransferase. Sorry, that's just transferase. Sorry, I don't know why that word's hard for me. But it's not specific to liver disease, but it can be increased in cirrhosis or liver cancer or hepatitis. And then GGT levels are basically cholecystitis, alcoholic liver disease. You'll see some elevations there. Additional diagnostic tests for the liver. They may do a liver biopsy, just go in and take a little chunk out, see what's going on, do an ultrasound, CT, MRI, or any other kind of imaging studies. If we're assessing a client to see what's going on with their liver, we're going to do a good health history, any exposure to hepatotoxic substances or infectious agents, any kind of travel, alcohol, drug use, lifestyle things that can be a factor. Physical assessment, we're going to look at their skin, right? We talked about if the liver's not working, you have that in elevated bilirubin, they may be jaundice. Or if they have those elevated ammonia levels, they may have a change in their cognitive status. And we're going to also palpate and percuss the liver. We shouldn't really be able to feel the liver, but if it's enlarged, we will feel it under that right upper quadrant, kind of poking out underneath the rib cage. And so we can percuss, if you remember from your assessment, or we can palpate that. Acute chronic cirrhosis of the liver. So you can have hepatic dysfunction. Again, acute or chronic cirrhosis that can be related to alcohol or non-alcohol. And so it's kind of interesting where we just think cirrhosis, we kind of just automatically always thought alcoholic cirrhosis, but people's diets are absolutely contributing to the death of their livers. So it's called non-alcoholic cirrhosis of the liver, but it's basically called NASH for short. But it's basically diet related, which is scary because we need to pay better attention to what we're eating. But anyway, that's another lecture for another day. But liver failure, again, associated with alcohol use, infection, or fatty liver disease, as you can see here. But typically it's called NASH or NAFLD. Manifestations of hepatic dysfunction, we kind of talked about it when we talked about what the liver does, but you can see jaundice, portal hypertension, ascites. So again, that we talk about edema with heart failure, with liver failure because of that backup from the portal vein having hypertension and it's backing up into the abdomen. Basically, they have this big old, like air quote, beer belly looking thing that's just full of fluid and can make it difficult to breathe. And they've just got this all of a kind of a displaced fluid placement where it's just like you would see edema in the legs, it's all in the belly, and that's called ascites. You can see varices, which is issues with the vein and the blood flow. And that varices, they can have them in the esophagus, but basically it's almost like little kind of aneurysms, those can rupture. And then they, again, back to that bleeding problem that you can see that as well. And then, of course, nutritional deficiencies. One of the other diseases of the liver is hepatitis. You can have viral hepatitis. This is It's a systemic viral infection that causes necrosis and inflammation of the liver. Um, it has characteristic symptoms and biological changes, and there are different types of hepatitis that start with letters. Non-viral hepatitis are basically caused by like toxins or drug induced. So hepatitis, again, thinking of a quick way to remember it because transmission will be something that you're tested over. So if you think about the vowels, think about the vowels. So hepatitis A and E, because again, A, E, I, O, U, and sometimes Y are vowels. So hepatitis A, hepatitis V are vowels, and it's caused or equaled in the bowels. They transmitted via the bowel, a fecal oral route, based on contaminated food or water, and you can get them by eating something you shouldn't have, meaning something you shouldn't have that was had hepatitis in it. And if you remember, when we did in 118 some of those ethical studies, unfortunately and disgustingly, that like people with intellectual disabilities that were in the home, that they were being given intentionally hepatitis by somebody again, and they were fed basically contaminated stool, which is disgusting. But thinking about it, as gross as it is, the A and the E, the bowels, equal the bowels. Number two, the consonants. So there's hepatitis B, C, and D, blood and body fluids. So hepatitis B, C, and D are consonants. Thinking about that, it just is an easy way to remember. Transmitted via blood and body fluids. So that's like IV drug use, sexual contact, blood transfusions, or mother-child during birth. So hepatitis A, spread by poor hand hygiene, fecal oral. You'll hear there's like outbreaks of hepatitis. I don't want to curse a fast food chain, but sometimes you'll see just again poor hand hygiene, and there's a hepatitis outbreak from food at a certain place. It takes about 2 to 6 weeks to incubate, and the illness can last 4 to 8 weeks. Basically, the mortality rate is kind of for the young, it's like 0.5%. And 1 to 2 for older adults or people older than 40. So usually if this is really kind of giving you an issue, you probably already have another like maybe problem where this is kind of ravaging you in a different way. But manifestations are flu-like symptoms, low-grade fever, loss of appetite or anorexia. Later manifestations could be jaundice because it's affecting your liver, dark urine because that bilirubin in the liver can look really dark, dark, dark amber color also. And indigestion, epigastric, oh my gosh, distress. So just kind of that heartburn and reflux and not feeling good there. And then enlargement of the liver and the spleen. This is an RNA virus that's basically seen in the adult population. Again, ingestion of foods or liquids that contain the virus. It's hand to mouth. So fecal oral, somebody has poor hand hygiene or whatever, and you're eating the virus that's probably been shed via the bowel and the digestive system. It's not bloodborne, but it can be passed through oral anal contact if there is intercourse or like fecal oral you figure it out. You got it. But no carrier state, no chronic course, and like patients usually are without symptoms for the most part. But again, think hepatitis A. I ate the word anus, whatever you need to do to kind of remember it. But again, transmissions fecal oral, and then mnemonic, you ate something that was contaminated from the anus. Hepatitis A usually happens again, restaurant poor hygiene or travelers drinking water that was contaminated. Management, prevention, good hand washing, safe water, proper sewage disposal. There's a vaccine for hepatitis A. There is a chart that kind of looks at this in your book, but hopefully you'll get what you need here. I don't know that you need to go digging too far, but it's an immunoglobulin that contacts to provide passive immunity, bed rest during the acute stage, and then of course just nutritional support as people need it, as they may not be feeling like eating while they're sick and infected with the virus, but hopefully it's not going to last too terribly long. But prevention is the key. Hepatitis B. Most people who develop hepatitis B develop antibodies and kind of recover in 6 months, but there's also a vaccine for this. I'm sure you, being in nursing school, you're quite aware. Clinical manifestations, it kind of resembles hepatitis A, but the incubation period is much longer. So the liver could be tender and enlarged. You can see an enlarged spleen and cervical lymph nodes on like imaging studies. Hepatitis B, again, thinking of those, a quick mnemonic, however you want to think about it. But hepatitis B, think B, body fluids, bed, baby. Basically, I'm getting it from blood, semen, saliva, or mom to baby can pass it. So think about those three B's: bedroom, sexually transmitted, blood, IV drug, or an accident where I got contaminated blood, needle sticks, etc., or baby passed from mom to baby during birth. This is the only DNA virus in the group. Everything else is RNA. I mean, that might seem like weeds, but it is just kind of a fact. But this is the only DNA virus. All the other ones are RNA viruses. Management of hepatitis B. For chronic hepatitis B, there's going to be like some alpha interferon or antiviral agents that they're going to take. Um, Listed here: bed rest, nutritional support, people that are at high risk, but of course vaccinations, which are given, as soon as your baby's born, they're giving them hepatitis B to try to prevent that. Passive immunizations for those who are exposed, and then standard precautions and infection control measures, and then screening of blood products, of course. So prevention is multifactorial. Again, screening, needle safety, immunization, of course, and then that passive immunity is the hepatitis B immunoglobulin. Medical management, we're trying to minimize the infection in the liver and the inflammation of the liver and to decrease symptoms because, so basically, those alpha interferon offers a lot of promises treatment, but it's really expensive, and there's a lot of side effects. So, of course, adequate nutrition and then protein intake is not decreased or restricted. So just think about, where even though the liver does synthesize that, we're not changing any protein intake and we're trying to, um, promote, them with supporting the nutrition along the way. May take 3 or 4 months for them to get better. Definitely teaching regarding safe sex and testing of any partners because obviously that is how it is transmitted. Hepatitis C, it's transmitted by blood and sexual contact. Again, it's another one of those consonants, right? Um, it's can be needle stick, sharing of needles. It's the most common bloodborne infection, surprisingly, but it is. Um, Third of liver cancer as a result of a previous hepatitis C infection. So a lot of times when you see people with liver cancer, they already had a history of hepatitis C. It's the most common cause. And then there's, again, risk factors there, but incubation period varies like 15 to 160 days. Symptoms are usually mild, so they may have it and not know it. So they can be a carrier and not even understand that they have hepatitis C because they don't maybe have a lot of symptoms. Hepatitis C, think circulation, chronic. I know that sounds, it's just, again, a way to get your brain to remember it, but it's blood to blood, blood contact, but you can get circulation, so you can get it via transfusion. It's crack cocaine. I mean, people aren't typically shooting up that drug in particular, but just thinking IV drug use is going to be the number one cause for hepatitis C. And then chronic, it's very likely to become a chronic illness, unlike A or E. This people will kind of, there's a medication for this, but talk about expensive, like, and it's almost like, to me, exploited in this way of people would want to take it, but I had a friend with a hepatitis C infection, and she spent, it was resolved. It was a long course of medication, but it was super super expensive. It's almost like they know that you want to manage it in this way and try to eliminate it, so it's like an exploitation of like how much are you willing to pay for it, which is sad but scary. Anyway, management: antiviral medications, alcohol potentiates the disease. So again, you maybe have somebody that has hepatitis C, and then if they also have a lot of alcohol substance use disorder, it can make it even worse. There's no real benefit from rest or diet or supplements like the other ones. Antiviral meds can achieve that sustained virologic response, so absence of the detectable virus, kind of like when we talked about HIV last week. Um, but it's basically a cure, but over 90% can be cured with, again, the medication that's like 8 to 12 weeks of oral therapy. And then the choice of meds is based on the degree of cirrhosis and the genotype. So, um, screening in the blood, and then of course safety needles for healthcare workers, so that we don't get blood exposure from just an accidental needle stick. So Hepatitis D. This is kind of an interesting one, but it basically you have to have hepatitis B for hepatitis D to be an issue. Blood and sexual contact transmission, again, IV drug use, um, patients undergoing hemodialysis, et cetera, people with multiple blood transfusions, highly unlikely, but it is likely to develop into fulminant liver failure or chronic active hepatitis and cirrhosis. So basically, it can kill your liver, but again, you have to have hepatitis B for it to kind of do its thing. The incubation period's anywhere from like a month to 150 days. And then the interferon alpha is the only licensed drug available. Again, only drug, really expensive, to treat hepatitis D infections. But it requires a hepatitis B antigen to replicate. So if you don't have a hepatitis B infection, you won't. Hepatitis D is not going to do anything. So kind of think hepatitis D is kind of defective and dependent on hepatitis B. Transmission is still blood. It's one of those consonants, right? Hepatitis B is a defective virus, can't survive alone, and it's dependent on kind of like dad, like the hepatitis B. So you can only get hepatitis B if you already have hepatitis D if you already have hepatitis B. So it's kind of like a super infection, or you can get them both at the same time as a co-infection. But um, yeah. Hepatitis E, another vowel, right? So think vowels, fecal oral route, contaminated water, incubation periods like 15 to 65 days. Kind of looks like hepatitis A, but it's kind of limiting, self abrupt onset, not chronic. Again, good hand hygiene, hand washing. So poor sanitation is more common. Jaundice is almost always present in hepatitis E. So think eating or yeast, like again, poor conditions. Fecal oral, eating contaminated water, undercooked seafood, most common in East Asia or developing countries. Dangerous for expectant mothers. It's a high mortality rate in pregnancy, unfortunately. Here's just a quick little table to kind of break them all down again. I feel like it. I'm hounding you on this because you're probably going to see it on test, right? So yeah, however you choose to work together to remember it, please do. Hepatic cirrhosis, there again, we talked about this a little bit, but alcoholic scar tissue characteristically surrounds the portal areas. Post necrotic, we can have scar tissue, and then biliary scarring occurs around the liver and bile ducts. Talk a little bit about pathophysiology and manifestation. Chronic disease characterized by the replacement of normal liver cells with fibrosis or like scar tissue. So those basically ends up normal liver cells are replaced by scar tissued liver cells that are sclerosed or cirrhosed. Thinking about how scar tissue, what we call it in other areas of the body. The liver is scarred. We don't call it hepatic sclerosis. We call it hepatic cirrhosis, but just know that's what's going on. Three types. Again, alcoholic is the most frequently caused, is most frequently, but I don't know that I feel like those numbers are probably changing. But it's caused by chronic alcoholism and it's the most common type. Post necrotic, it's usually proved you had hepatitis and as a result it damaged your liver to the point that after the infection you have this post-necrotic cirrhosis. And then biliary results from a chronic biliary obstruction like your gallbladder or bile duct infection, and it basically kind of blocked the ducts and things couldn't leave and it started to damage the liver as a result. And then of course there's non-alcoholic cirrhosis that looks pretty much just like the alcoholic cirrhosis as well, but it's caused by fatty liver disease and based on diet. Portion of the liver that's involved consists of the portal and periportal spaces, so right around that portal vein, which is where you end up seeing the portal hypertension because that's where it's damaged. The bile, each like lobule communicate from the liver and the bile ducts. Communicate from the liver and bile ducts. Those areas can be a site of inflammation. And the bile ducts get occluded with thickened bile and pus, and then the liver tries to form new channels, and this causes like an overgrowth of tissue. So it just basically gets is disconnected, newly formed bile ducts, but it's all surrounded by scar tissue and is not working effectively. Nutrition deficiencies result, if they have um, reduced protein intake, it can contribute to liver destruction and the cirrhosis, but can also occur for people again who don't drink, have a normal diet and high alcohol intake. So basically, you can also have exposure to chemicals, arsenic, phosphorus, carbon tetrachloride. Infectious, again, you can have I can't really say this word very well, but it's basically a schistomiasis. It's a worm that's in fresh water, like snails. It's kind of weird, but it's like a uh, um, parasitic infection. Alcoholic cirrhosis, again, episodes of necrosis involving liver cells can recur repeatedly throughout the course of the disease. Um, and destroyed liver cells are replaced by scar tissue. And then eventually the amount of scar tissue is greater than the amount of the functioning liver, which is where you see end stage liver disease. So you have kind of these islands of normal tissue and regenerating tissue. But eventually, the poor sclerotic tissue is outweighs the healthy tissue. You can have insidious onset, and sometimes you can have just kind of chronic and it lasts longer than 30 years. So, signs and symptoms increase as the severity of the disease progresses. So, basically, we can look at compensated versus uncompensated as kind of how we look at this cirrhosis. Um, so compensated is kind of less severe, symptoms are vague, can be, secondarily discovered like during a routine exam. Decompensated, you see symptoms. So liver failure thinking, clotting factor issues, liver enlargement, portal vein hypertension, um, large liver cells loaded with fat. The liver's form and has kind of a sharp, palpable edge. Later in the disease, though, the size decreases due to the scar tissue kind of contracting. If you think about how scar tissue is when you see it on your skin, it's the same in your liver. So it kind of starts to shrink because the scar tissue hardens and contracts. The liver edge is kind of nodular and palpable if it's palpated. You can have portal obstruction and ascites, late manifestation. So think end stage liver disease. If you're starting to see portal hypertension and ascites as a result, we are late stage. It's caused by chronic failure of the liver and obstruction, and almost all the blood from the digestive organs is collected in the portal veins and goes to liver. So cirrhotic liver does not allow free blood passage, so it backs up into the spleen, the GI tracts. The organs become kind of this seat of congestion, and they're all like stagnant with blood, and it can't function properly. So that's where you see the indigestion, the altered bowel patterns, and this is the fluid is it's rich in protein. It can accumulate in the peritoneal cavity, and then that's where you see the ascites. So it's seen on the physical exam as kind of a fluid ways. If you palpate it, it's dull when you palpate the and percuss the abdomen. You can have an infection or peritonitis. You can have a bacterial peritonitis, even without a sort of source of infection. And you can have bacteremia because you basically get translocation of intestinal flora now into the abdomen and where that's normally sterile. You can treat with antibiotics, and of course, paracentesis is where you tap the um, belly basically to get the fluid out of there. So we talked about kind of like chest tubes and thoracentesis, or getting liquid out of the lungs. This paracentesis is getting the liquid out of the abdomen. And then, of course, we're going to culture and maybe even send it for pathology if we need to. Spontaneous bacterial peritonitis is a kind of factor when we're starting to get into hepatorenal syndrome. So basically, now our kidneys are being affected as well. And we'll talk about those next week. But basically, we're going to try to give fluids or diuretics, but there's kidney disease that's characterized by a lack of pathological changes in the kidneys. So it's hepatorenal, meaning that now my issues with my liver have affected my kidneys, and I didn't have a primary kidney disease. So there's not really any evidence of dehydration, etc. GI varices, again, that's the issues we talked about a little earlier, but the obstruction of blood flow in the liver. So you have fibrotic changes, and then you have collateral, all these blood vessels in the GI system and shunting of blood from the portal veins. But you get all these like kind of like alternate blood circulation, outlets that are kind of trying to create new vasculature, basically. But you basically have prominent distended abdominal blood vessels, and then you can also, it's called caput medusae. So basically, like think about Medusa, like how she has all those snakes coming out of her head, but basically you have like all these alternate blood vessels that are being created kind of in that same, that's what it looks like. But you can get them in the esophagus and the stomach, and especially in the esophagus. Again, they're very kind of frail, kind of protruding to the surface, and there's a lot of blood flow, and then think my clotting factors don't work either. So sometimes people can have like a very fatal esophageal varice rupture, where they bleed to death, and can kind of aspirate and just have all these issues that it's hard to like manage at end stage liver failure. The lower rectum are another common site for varices, so hemorrhoids. And again, they can rupture and bleed because these vessels are not intended to carry such high pressure and volume. And my clotting factor stinks. So, again, no good. Um, Edema's late stage, again, that ascites late stage. So I don't know if I can say that anymore, but ascites is late stage renal failure, but you have basically reduced plasma and albumin concentration, and it predisposes the client to edema and ascites. It's usually bilateral upper extremity edema, pre-sacral, so before the sacrum, basically. You don't usually see facial edema with somebody with end-stage liver failure. So it's all pre-sacral. Vitamin deficiencies and anemia, again, especially vitamin A, vitamin C, and vitamin K. Um, Definitely that hemorrhagic phenomenon are related to the clotting factors and the vitamin K deficiency. So you can have anemia from chronic gastritis. You can have inadequate, dietary intake that's affecting your liver anemia, and then impaired liver function, just poor nutritional status and overall poor state of health, and then so lots of fatigue. Again, that mental deterioration that we talked about. So basically, hepatic encephalopathy, which isn't the same as I know we've seen in the clinical setting. Some clients that had dementia as related to alcohol consumption, but this is different. This is that we're talking, remember about that ammonia level that's high. We can really have an issue where they're having encephalopathy and even coma, so a change in level of consciousness. Again, the key term there, thinking about some worry for our client. So we're going to do labs and diagnosis. We're going to look at those liver function tests again, ultrasound, CT, MRI, and then the diagnosis is confirmed by a biopsy of the liver cells that we see that they're sclerotic. Um, Medical management's really at this point just based on presenting symptoms, but the medication in the book, one of them I want you to know, key like medication minute is going to be lactulose. So that is a medication takeaway for our liver hepatic area, and we'll talk about lactulose. Care of the client with cirrhosis of the liver. Again, we're going to promote rest, nutrition, skincare as we need it, and even let out that elevated bilirubin. And don't get this confused. So elevated bilirubin, that's where we're seeing the jaundice. They can have itching. They almost can get these like crystals on the skin. It's really kind of weird, but just know, think bilirubin. Um, that is more manifestations of the jaundice that you're going to see, jaundice in the sclera. So their eyes are yellow, their skin, their peeing kind of, their elimination also looks like it's got this bilirubin. So you're going to see that jaundice. Ammonia levels, again, I please hear me, but the ammonia levels is what really causes the confusion and the hepatic encephalopathy and eventually the coma, that byproduct from the hemoglobin being broken down that the body's not able to do anything with because that's what the liver does. So we're gonna and that's where they would be given the lactulose to try to combat that, try to get them to pull that back, the ammonia back into the GI tract so that they can excreted out. The downside of that is that they have probably multiple loose stools that sometimes at this point they may even be a little incontinent, but they obviously have to be able to ingest it. So there's that balance of trying to ingest it enough to manage the liver, but them not being so encephalopathic or in a coma, they obviously can't ingest it. So, I mean, could be given like via NG, something like that. But again, there's just this delicate balance with end stage liver disease trying to um, manage the symptoms versus the interventions. Um, Risk for injury, of course, if we're having change in level of consciousness, we can have aspiration issues or just confusion, falls. And then if they're falling and they don't have good clotting factors, then we're at risk for bleeding. So again, you can see where the cycle is going. So we're monitoring and managing any kind of potential complications. And there is a little chart in your book. I think it's like 4310 that kind of talks about all this. So if you want a little bit of further visual for this. Again, promoting rest, supportive measures, oxygen if they need it, um, any kind of mild exercises if possible, but again, nutritional status, again, preventing hazards with immobility, but also mobility that's unsafe, fall risk, etc. And then also, and when we think about oxygen, really the bigger issue is sometimes that ascites, that late stage, can make it hard to breathe. So it's really supporting that. And then, of course, that paracentesis to um, get that fluid off the tummy. Um, I know we're going to monitor, encourage frequent small meals and high calorie diet with low sodium to kind of try to combat more ascites. Because again, remember in the normal situation, where sodium goes, water flows, and so they're going to be fluid overloaded if they're getting too much salt in their diet. Protein, it might be modified or restricted if they're having really increased risk for encephalopathy, because they're that again they may have more issues with like their hemoglobin and other things. So supplements, vitamins, B complex vitamins, especially water soluble, fat soluble vitamins if the patient has like that oily um, bile looking stool, that steatorrhea. And then whatever the patient's preferences are, like I said, that can be kind of a delicate balance. If the client with patient does not have ascites, edema, or signs of impending hepatic coma, those clients will get the high protein diet with a supplement of vitamins, again B complex A, C, and those small frequent meals. If the patient has the steatorrhea or that really oily bile looking stool, like almost like a diarrhea, but it's like liquid and oily and yellow and kind of looks like bile, they're going to receive water soluble vitamins A, D, E, folic acid, and iron to kind of prevent anemia. So hopefully that makes sense. Again, I will say it again. So if the client does not have ascites or those signs that are in stage and they're not in a coma, high protein diet, small frequent meals, vitamins A, C, B, and then also vitamin K. Again, and if they do have a little bit of ascites, we are thinking about small frequent meals again based on the pressure in the tummy. And then if they have that steatorrhea or that biley, oily stool, those we're going to focus on some water soluble vitamins A, D, and E, folic acid, and iron to try to prevent anemia because they've already, they're having some issues, and those are kind of the manifestations of that. Um, Further support nursing, skincare, you know, reducing risk for injury. They can have subcu edema, again, immobility or poor mobility, jaundice, and increased susceptibility of skin breakdown and infection. We're going to try to manage any of those things. And then hepatic encephalopathy, you can see that kind of delirium, physical changes, abnormal voluntary and involuntary movements, elevated pneumonia levels, and lactulose. So again, hepatic encephalopathy is related directly to ammonia, not bilirubin. They can develop cardiovascular issues based on um, peripheral vascular resistance, and maybe even release of vasodilators if they have that hepatorenal syndrome. A hyperdynamic circulatory state, so they basically gets more severe as decompensation progresses. So monitor for increased fluid, ascites, bilateral lower extremities or upper extremity swelling, dyspnea, again, not in the face, but edema in the body. Um, INOs, daily weight. We can measure abdominal girth to kind of track the ascites. So you would pick a spot, usually around the umbilicus, that you're going to measure every day in the same place. So that way, as I trend it, I am measuring in the same spot. I'm not measuring one place and then you come in tomorrow for your shift and you measure somewhere else. So, but we can measure abdominal girth, looking for nocturia or increased urinary or oliguria, like later stages. They're having some issues with, urinary output. Portal vein hypertension, first step, kind of fluid, trying to manage that. It's the first step toward fluid retention in the setting of cirrhosis. So a patient with cirrhosis, but without pulmonary hypertension, typically does not develop ascites or edema. So again, there's a chart in your book. I think it's like on 1394. But it's 43-9. It's compensated versus uncompensated cirrhosis. I would want to kind of focus on that if I were you. And that is the end of our hepatic lecture. Okay, our medication moment for this concept is lactulose. Remember, we were talking about when we have cirrhosis and hepatic encephalopathy and we're having issues with our liver, that one of the primary functions of the liver is to kind of regulate and consolidate that ammonia byproduct in the body. And since it cannot do it because of the dysfunction of the liver, the hepatic dysfunction, we give lactulose. Lactulose class, it's actually an osmotic laxative, which seems a little odd, but it's true. But it's other pharmacologic class besides being an osmotic laxative is being an ammonium detoxicant. So basically a synthetic disaccharide that is basically absorbed, it like grabs sugar, fructose that's not absorbed in the GI tract and kind of works as an osmotic laxative. But primary indication again would be chronic constipation for lactulose, but we use it we use it to treat constipation by softening stool, based on that yeah, indication on the left side here. But hepatic encephalopathy is another indication, and a very common primary reason that we give lactulose. So we use to prevent and treat the portal systemic encephalopathy in liver disease patients. So that client with cirrhosis who can't do anything with that ammonia byproduct, we are giving lactulose for that hepatic encephalopathy. And remember, it's the ammonia, not the bilirubin. Okay. So the way that it works basically as an osmotic diuretic, and it's still also how it works to grab that pneumonia, but we'll look at that. Ammonia, goodness. Lactulose is poorly absorbed in the small intestine, so basically it remains in the intestine lumen, creating a really high osmotic pressure, and we know like that has to do with like when talked about IV fluids and stuff like that, how things flow in and out to try to get this magical homeostasis. So the effect is that it draws water from the surrounding tissues into the colon. Remember, it's high in sugar, right? So it's gonna like suck it on in there. And increase stool volume, which stimulates peristalsis and then in turn evacuation and passing of stool. But basically that ammonia trap, so what it does, if you kind of look, there's a picture here of the urea cycle and how we end up with high levels of ammonia. Oh my gosh, of ammonia. So basically that acidification, so there's, colonic bacteria that degrades lactulose into lactic acid, acidic and formic acids. You don't have to know like exactly the how, I know we talk about the mechanism of action. We're not pharmacists. You don't have to quite get that part. But basically the number two, that basically that acidic environment converts ammonia into ammonium. So you can see it's like NH3 gets converted to NH4, and then we just basically excrete it out. So unlike ammonia, ammonium can't cross the colonic wall back into the bloodstream, and so it gets trapped in the bowel, and then it gets excreted into the stool, which is exactly what we want. So basically, again, think about those high levels of ammonia in the blood. What lactulose does is grabs all that, takes that NH3, adds another hydrogen, and then turns it into ammonium, which cannot be reabsorbed in the bloodstream, and then we poop, basically poop it out. And then side effects, GI discomfort, unfortunately, gas, bloating, abdominal cramping, because obviously we're kind of increasing that peristalsis. It can be, especially at the start of therapy or a changing in dosing. Dose-related excessive dosage can lead to nausea, vomiting, and severe diarrhea, and then the dose may need adjustment. And then metabolic risk, prolonged severe diarrhea can cause dehydration and hypokalemia, and also hypernatremia from dehydration. So again, it's like this balance of like we don't want our clients to be encephalopathic. We don't want them to be confused, and honestly, if the levels get too high, they can even go into a coma with complete changes of level of consciousness. So we talked about that with like that neuro section. We do not want big changes in LLC if we can avoid them. So this is where we're doing kind of this delicate dance with lactulose to try to like balance the side effects, but also that intended use we're also focused on. Nursing considerations, we're going to monitor labs. We're going to keep checking those ammonia levels. They ideally should decrease. We're going to watch electrolytes. So we're going to watch for, potassium and sodium changes, and then assess the status of the client. We're going to do, orientation, LOC, in those hepatic encephalopathic patients. We're going to try to see, that improvement of their cognition will indicate that we're having success and effectiveness of the lactulose regimen. And then again, titrating the dose for hepatic encephalopathy. The goal is typically 2 to 3 soft stools per day, and we're going to adjust accordingly. But again, it's that risk versus benefit too, right? That just common sense education of like, if my client is completely having absolutely uncontrolled stools and they're alert and oriented, they're going to kind of decline to take it because unfortunately, those side effects, at this point, are too much. So again, we're going to look at that balance. So ideally, we're going to get improvement in their LOC and still hopefully only have 2 to 3 soft stools per day. Client education, we're going to do key teaching points. Taste, it's kind of really, really sweet and syrupy. So in helping them to make sure they take it all, but maybe they should mix it with fruit juice, water, milk to kind of improve the palatability of it. Again, just let them know, educate them about the side effects, that they're common and they usually decrease as the use is continued. So they'll like get better with time. Hydration, drinking plenty of water to prevent dehydration from increased stool output, and then warning that severe persistent diarrhea, let the healthcare provider know immediately so maybe we can do some adjustment of the dosing. Test your knowledge. What is the therapeutic goal for a patient with hepatic encephalopathy taking lactulose? Um, if we talked about like, what do we want to see? Pause here if you want to. I'm going to go on to the answer. The answer is improved mental status and 2 to 3 soft stools per day. Test your knowledge again. Which electrolyte imbalance is a major risk with excessive lactulose use? Which one will we be most concerned about immediately? Um, Not that there weren't two, but there's one for this one. So technically, you probably won't be wrong, but we can think about that. Probably that most immediate one you'll see right away. Hypokalemia, low potassium due to diarrhea. And that is the end of your hepatic lecture.